All right, good evening, everybody. Welcome to the webinar Revision Techniques in Scoliosis put on by the Harm Study Group and the Studying Scoliosis Straight Foundation, and also sponsored by Highridge. We'll let people continue to funnel in, but if you can go to the next slide. Tonight, myself and Mark Erickson are going to be moderating the event and helping us get through the various talks. Next slide. We really are fortunate to have an outstanding faculty, not because we all like dealing with complications, but this group is very experienced and therefore knows how to get out of trouble. And so they'll be introduced individually before their talks. Next slide. So a few sort of nuts and bolts, if you guys could submit questions through the Q&A section of the Zoom. We will field those questions. Some of those we may answer, but also some of them we'll bring to the discussion at the end of the talk as we feel relevant. Next slide. And so this is our agenda, sort of 6 really great opportunities to learn about how to deal with some complications following scoliosis. And again, we'll talk about each of these a little bit more in detail as we get to those individual topics. So the Studying Scoliosis Foundation really is behind this and really finds educational opportunities that are really important for all of us. We are a nonprofit organization that's been here since 2018 with a mission to better discover and advance techniques and treatment of scoliosis in children and adolescents worldwide. So our vision is really to improve the care of the children that we take care of, and educational events like this really help us do that. Next slide. And now I'd like just to introduce John Quinn from Highridge, who has generously supported this webinar and has a real dedication to education in the pediatric spine space. John, take it away.
Thank you very much, Dr. Glotzbecker. I'll make this very quick because I appreciate nobody dialed in to listen to John Quinn talk about Highridge Medical. But just quickly wanted to share with you our leadership, which has a very, very strong focus and background in spine. We are one of the world's largest privately held pure play spine companies, and we're 100% focused on spine, committed to developing innovative procedural solutions in collaboration with our surgeon partners. And I wanted to share a little bit about our facility that I'm sat in now. We have an on-site bioskills lab with 8 cadaveric stations. We have an ISO accredited mechanical lab downstairs and a biomechanics research lab. And I would invite anybody on this call, if you want to come and visit us here at Highridge, you're always welcome to come and have a look at our facility. We do surgeon-to-surgeon visitations, regional bioskills, and the cleaning staff have just turned the lights off in the room I'm in, so hopefully you can still see me. But we would invite you all to visit one of our Summit the Ridge surgeon visits here at our headquarters. Here's some of the societies that we support, and I thank you very much for your attendance.
Great, thanks, John. And again, the importance of Highridge and their mission to help with these educational events, we couldn't do it without them. And we're very much aligned in sort of providing these opportunities to improve the care of our children. So now I'm going to introduce Pat Cahill, who is going to present on our first topic, revision following surgery for idiopathic scoliosis. And Pat, you're up.
Great. So again, I'm excited to be talking about one of everybody's least favorite subjects, which is adding on. These are my disclosures, none of which are particularly relevant for this talk. So I'm going to talk about what is adding on. I'm going to try to define it as best we can. I'm going to talk about what some of the factors are that might predispose some of our patients to having this unfortunate phenomenon occur. Then I'm going to talk about what we can do about it, or some of the things we can do to prevent it, and maybe modify some of those modifiable risk factors. So first of all, defining adding on is a hard thing to do. It's one of those things that we know it when we see it. It's some sort of progression of deformity adjacent to an instrumented construct. But when it kind of really try to parse it out exactly what's adding on and what's not, it's a little bit more of a gray zone. So certainly when there's an increase in a curve in the uninstrumented areas, particularly when it's a curve that's extending from the distal or the proximal end of a construct, or that curve starts to have a apex that's a little bit more and more distal, that's probably adding on. Wang has given some numerical definitions to it, and certainly Cho has as well. And these are the ones that most people use. If there's an increased deviation of the lowest instrumented vertebrae from the midline, from the central sacral vertical line by a centimeter, that's adding on. Or if it increases between 5 and 10 millimeters and there's an increase in angulation of the disc immediately below your construct, that's also defined as adding on. And so the harm study group who's sponsoring this has a huge database of AIS cases. We looked through that and we found that about 6 to 7%, 6 to 7% of cases have adding on. And then other people have also looked at the adding on phenomenon and come up with some of the predictive factors. Certainly maturity is a big one. The younger your patients are, the more chance they have for growth and therefore progression of deformity and therefore adding on. The bigger and badder the curve is that you fuse, the more likely there is to be adding on adjacent to it. And then those patients that are out of balance before surgery are more likely to have an adding on phenomenon afterwards, either because they are trying to get back into balance or they're trying to get back to their preoperative state of imbalance. There's a number of modifiable factors as well. I think if we do a good job derotating the lowest instrumented vertebrae, there's some good evidence that shows that we can prevent adding on in that way. Also, if we undercorrect the main curve, we're likely to see some adding on as an attempt to balance the residual fuse curve. And then I put as a modifiable factor the lumbar curve in the uninstrumented areas and the first erect X-ray. And I'll touch on this a little bit more when we go into the risk factors associated with VBT. Interestingly, one of the things that we're starting to look at more is apical vertebral rotation now that we're getting 3D data as well. So stay tuned to see how important that is. But certainly the lowest instrumented vertebrae we want to derotate. Ben Roy and Mike Vitale looked at the impact of adding on HRQOL, and it unfortunately is something that has a negative impact on our patients when it does occur. There were statistically and clinically significantly increased or worsening of scores in the subdomains of pain and activity, but interestingly, not necessarily for appearance. But this is sobering data. It certainly is not just a radiologic phenomenon. It's a real health-related quality of life phenomenon. The group from Korea looked at the incidence of adding on in lumbar fusions as well. And they found a whopping 28% risk of adding on. And some of the risk factors were, again, bigger, badder curves, or if you ended at L3. A little bit more of a nuanced dive was from the Paris group. And they found a 10% incidence of adding on. And they found that if your construct was short of the stable vertebrae or the last touch vertebrae, you were significantly more likely to have adding on phenomenon occur in your selective lumbar fusions. Now let's turn a little bit to VBT. Some of the risk factors for adding on are similar to what we saw with fusion, which makes sense. The straighter we get the curve, the less likely there is to be some adding on. Again, imbalanced patients preoperatively are going to lead to some weird things happening in the uninstrumented levels postoperatively. But some of the modifiable factors I think are really important in VBT that we're learning. Percent correction of the main curve is really important to drive the correction of the uninstrumented levels also in VBT. One of the lessons we've learned the hard way is that if there's a parallel disc, we need to include that in the construct. Don't be tempted to go a little bit shorter. Maybe overcorrection is something that can lead to adding on. Remains to be definitively associated, but probably is. And then again, this issue of first erect lumbar curve correction, and I want to touch on this. In the era now that we can add VBT in the lumbar spine, either after we've done a thoracic VBT or as part of a hybrid construct, I think this becomes a modifiable factor. And if we see our patients standing up immediately post-op and have a big lumbar curve, we can act on that during the same hospitalization. And ideally, I would say we should probably, in patients that we're worried about with a borderline lumbar curve, we should have that discussion and plan on that ahead of time with our families. So this becomes part of the course of care and not some sort of bailout or salvage or surprise for our families. So I put this as a modifiable factor because we can certainly jump on a large residual lumbar curve. And then I'm just going to finish with a case example of a kid I did a tether on, a young patient with a very flexible curve. And it looked great for about 18 months, but then this is what we had. This is clearly adding on. we see about a centimeter lateralization of the apex of this curve. We can see an increase in the angulation of this disc, clearly more than 5 degrees here at this disc below the construct. And this is my only treatment slide because the treatment is easy. You just have to extend your construct one way or another. You can extend it by doing a fusion, or if you've done a tether and the patient's still immature, I think that's a reasonable treatment. Which is what I did in this case as well. The decision making, again, is a little bit more opaque, but certainly I would like to see a curve that's at least 35 degrees that seems to be progressing on subsequent x-rays on probably about 3 or more visits in a row. That's when I make the decision to extend my fusion and finish it. And the last thing I'll say is connective tissue disorders are horrible. The adage, when in doubt, fuse long for these kids is very much true. And adding on is something that can occur even very late after surgery in things like Marfan syndrome and Ehlers-Danlos. Thanks, and hopefully everybody gets to spend some great time with their families in the next coming weeks.
Great. I just want to remind everybody to put their questions in the Q&A at the bottom of the Zoom. And we can probably, there's no questions for this, but if they come in, we can direct them to Dr. Cahill, certainly.
Next up, this is Mike Glotzbecker. He's going to talk to us about management of infection after pediatric spine surgery, a dreaded complication. Take it away, Mike.
Again, I think it's, appreciate the opportunity to be here and talking about another one of those things that none of us want to deal with, but we all have to deal with. So talking about when you get an infection, how do you deal with it? I have no disclosures related to this talk. So we're going to talk a little bit about how do you diagnose a postoperative spine infection, and then a little bit about management. So there's a little bit of treatment variation, and then I really think it's a divergent pathway from acute versus chronic infections. So what do we actually want to know? How do you diagnose a spine infection? What is the initial treatment? What is the long-term treatment? And what is the risk of recurrent infection? And finally, if you have to take the implants out, what are the chances that your curve is going to progress? So just to level set things a little bit, we need to know what the definition is. And I know it's a bit arbitrary, but it is considered to be an acute surgical site infection if it's within 90 days of your index procedure. And that's just important from both a reporting standpoint as well as how we treat it. So a little bit about diagnosis. So an acute infection is obvious. So pain, drainage, erythema, they often are sick. They have fevers, chills, or sepsis. This is the kind of thing when you see it, you know it. And if you don't think it's infected, you're probably just ignoring it. Latent or chronic infections, meaning those beyond 3 months, are much more difficult to diagnose. They may have subtle pain, implant loosening, and may even present as pseudoarthrosis very late. Labs are obviously important. Certainly early, things like CBC with diff, ESR, CRP are going to be elevated in acute infections. It's important to get blood cultures. The problem is these patients come up later, these labs may be very normal. As far as imaging goes, radiographs are often normal in an acute infection, as you'd expect. However, as you get into the more chronic infections, if it's chronically infected and they have pseudoarthrosis, you may have broken implants. And similarly, in chronic infections with pseudoarthrosis, you may see loosening around the screws, bone destruction, and or other evidence of pseudoarthrosis. Ultrasound is actually quite good, particularly in the chronic infections, and this is unpublished just because I haven't gotten it across the finish line, but it is actually the most sensitive in chronic infections, and it's abnormal in 86% of chronic infections. And so it's a very accurate diagnostic tool when you're otherwise unsure of what it is, particularly if the labs are normal. Advanced imaging has some role, but not a lot. You can get an MRI with GAD, which may show abscesses or epidural collections. The problem is that the implants often disturb what you can actually see. And postoperatively, there's a lot of inflammation that make it far less reliable. And the final tool is if you really are stumped and you can't figure it out, you can get a PET scan, and this can help you diagnose in a chronic infection that you're not really sure about. It's not affected by implants. It's relatively low radiation exposure. And it's very good, but it's high cost, and you really only need to do this if you get to the point where it's difficult to figure it out. Aspirating this is probably useful, and you can do this with either CAT scan or ultrasound. It's only got about a 40% yield, but it's a fairly low risk, particularly if you see a fluid collection on your imaging. So consensus around diagnosis are pretty similar, like it's sort of acute infections. If they're sick, you sort of know it. You should get blood cultures, you should get labs. And you should think about an aspiration. And then if you take them to the OR, you certainly should get cultures. So what about treatment? Well, the problem is treatment is all over the place. So if you ask people how they treat it, some people debride it once, sometimes they do it multiple times. Do you keep the implants? Do you take them out? Do you replace them acutely? What do you do with the allograft? What do you do with drains versus a vac? What antibiotics you use? What do you use from topical antibiotics? I will tell you that it's a bit all over the place. There are a few things that we know. If you have a chronic infection that's greater than 3 months old, and there is a very low success rate with implant retention. And Dr. Cahill wrote one of these papers. Another paper came out of Boston. Essentially, if you are presenting greater than 3 months, the chances of you being able to successfully retain implants is very low. And the problem with this is that you keep on taking them back and you just don't ever succeed. And so this leads to long hospitalizations, lots of dollars, and high indirect costs for the families as well who miss school, work, and the psychological impact of being sort of in the hospital for a long period of time. We also know that this is likely a soft tissue infection. So if you take the implants out, we are successful in clearing the infection. It doesn't include the bone. The question is, if you take the implants out, is your curve going to progress? And the answer is probably, although not all of them, but probably about half will progress. But if you clear the soft tissue infection, you can always go back and re-implant and get that back. So in chronic infections, I would say that you should remove the implants early, and you may need to re-implant later. Acute infections, less than 3 months, is a little bit different. So there's actually pretty good evidence that you can have good success with implant retention. About 75% of the time, you can be successful. One of the risk factors that we found with failure is actually having stainless steel implants. The good news, this is a bit historical now. And so I think our chances of succeeding with acute infections is probably even better. So how do you do it? Well, there's some variability. Certainly, should IMD, you can either retain or exchange implants acutely. Most people think you probably should remove the graft. I think you use some betadine irrigation and or topical antibiotics. Most people close over drains, and then most have a course of IV antibiotics to PO. And this is consistent. There's a best practice guidelines that Dr. Sponseller recently put out. And again, these things are pretty consistent with that. So for acute infections, either retain or immediately implant, exchange these kiddos. Certainly if it's stainless steel, which is pretty historic, you should exchange it. And then most get IV antibiotics for 4 to 6 weeks or 2 to 6 months of oral antibiotics for suppression after. So these will be available because the webinar is being recorded, but I think that I've created sort of this pathway, which sort of represents what I just told you as far as how you diagnose for acute versus chronic. And similarly, how do you treat them if they're acute versus chronic, which again, follow 2 different very pathways. So thank you, and I appreciate the opportunity.
I don't see any questions in the chat, but Mike, I'll fire one at you. This is a topic that comes up a lot, and I think as far as what to do. At our institution, we've come up with the sort of theory that on the acute infections, which is the hardest ones to take care of, in my opinion, where you're trying to retain the implants, we'll tell them they're going to be on antibiotics until such time we feel like we can take the implants out if it comes back. Do you have a philosophy or any kind of science to back up how you do your antibiotic protocol?
It's a little bit all over the place, as I said. I think the problem, we all do this a little bit differently, especially in a kid that's a higher risk to take back to the OR, where most of our infections come, the neuromusculars. I keep them on as long as they'll tolerate it, because I figure if I can suppress them for 6 months or a year, it's worth it to keep them coming back from the OR. Now, the healthy kids, I think there's some side effects to the antibiotics, and probably taking those implants out and going back and reimplanting them is less of a physiologic hit and less of an OR risk. I generally don't keep them on quite as long. They generally are on probably 3 to 6 months, and then we move on. But I have some neuromuscular kids that I'll keep on for a year because I just don't want it to come back, and I'm hoping that we can just sort of keep on going.
Agree. Great plan. Looks like we're right on time. Next up is Arun. Arun is in sunny South Florida, talking about CSF leaks, an unfortunate occurrence, but it does occur. I think recognizing them is the key, right, Arun?
That's right. We'll get right into it. All right. Thanks so much for having me, and thanks for being here, everybody that's on. These are my disclosure, none are relevant, except for that I really do hate CSF. I'll start with 2 examples that kind of got me interested in this topic. This is idiopathic scoliosis, healthy kid, no problems with surgery, no osteotomies. He comes in at 4 weeks complaining of orthostatic headaches, photophobia, and he told me the day before he was trying to get back into his CrossFit shape. So we got an MRI as a fluid collection, suspicious for CSF, proved it on CT myelogram, and we treated him with bed rest followed by epidural blood patches, which worked out well for him. And then I'll contrast that with this case as a 9-year-old with a severe congenital kyphoscoliosis. We did a 3-level resection and fusion on, and there's an intraoperative tear that was recognized and repaired. However, on day 2, I was making rounds and see this target sign and a little more of a complex situation that required return to the operating room for fixation. So CSF remains a little bit of a mystery, even from Dr. Dandy's original work in the early 1900s on dogs. The exact role is a little bit unknown. There's about 150 cc's of it in the body, and it certainly cushions and floats the brain and provides metabolic support. And the incidence of CSF leaks in pediatric spine especially is rare, but it's known to occur. It's 0.3 to 3.5%. There's certainly a higher risk in revision surgeries when there's 3-column osteotomies, and in certain conditions like NF1 and Marfan's where there's dural ectasia, or in other conditions where the soft tissues are not so good, and especially in tumors like this large subarachnoid cyst that got a decompression, resection, and a fusion. And it can present immediately in the operating room, or it can present in a delayed fashion. The causes can be from instrumentation malposition, like a medial screw. There's even reports of it happening in VBT cases. Osteotomies can certainly cause it, like in the prior case I showed where some of the nerve roots that were taken, the redundant ones, were the source of the leak. And if they have spinal cord stimulators that are adherent to the dura, when you go in to remove them, they can cause them. And some institutions use intrathecal morphine as part of their pain protocol, and those have been reported to cause CSF leaks as well. If it's intraoperative and you see a gush of fluid, you know what it is. And some really small ones may require a Valsalva maneuver in the operating room to recognize them. But the ones that occur after the operating room are the ones that are more challenging to diagnose sometimes, because the differential can be quite variant when it comes to headaches. But if they're presenting with postural headaches, nausea, vomiting, if they have a drain in place and you see obvious uptake in the drain output, or it's clear, then you have a pretty good idea. And there's most of the work on these delayed presentations from this Japanese group that showed that it occurs anywhere between 2 days to 6 weeks post-op, and the causes are variable. It could be a bone spur that was left behind. It could be excessive activity, but if there's CSF coming out of the skin, it's usually an emergency, and the occurrence of these later ones are much lower than the intraoperative ones, but they still occur. The diagnosis is sometimes obvious, like in a target sign. If you need lab work to really confirm your diagnosis, beta transferrin can be sent. There's prior studies of dipsticks for glucose oxidase, but it's not so sensitive. MRI can be quite good, and then CT myelogram to really pinpoint where it's coming from to intervene. From a management standpoint, suturing it directly is the gold standard. Biomechanical studies have looked at different types of sutures and different techniques of suturing them. And really not a huge difference between interrupted running and locked runnings, but Gore-Tex seems to work better in the lab, but in vivo, I think using any monofilament and getting a tight closure works just as well. Titanium clips have been described, not just in brain, but also in spine. These are non-penetrating clips, and you apply them the same way you might a vessel clip that comes in a disposable gun that you can load. And again, in the lab, these seem to be the strongest compared to any sort of suture. But again, clinically speaking, I think getting a tight closure works just as well. There are various commercially available sealants, from polyethylene glycol to fibrinogen-based. Prior randomized controlled trials have shown that once you suture repair it using a fibrin glue, either in a primary case or in redo cases, don't really seem to make a difference on whether or not the CSF leak recurs. But newer studies have shown that maybe that's not the case. Maybe the glues have improved, and I tend to use it every time I do a repair. It's easy to apply and the risk is very low, but there are case reports on this causing Kodak-Weiner syndrome or neurological issues from expansion of the dural sealants. If it's a larger tear or the closure is not so great, you can use autologous tissue grafts. Fat's been most commonly used. It's easy to get, has stem cell potential, but the dura mater and muscle come from the same paraxial mesoderm, embryologically speaking. So using muscle graft has taken a lot more, it has been shown to be pretty beneficial, especially if you use a pedicled muscle flap on big ones, but coverage is the key. And if it's a really big tear, And most of this data is derived from brain studies, including from our own Dr. Samdani. You can use artificial dural membranes that are commercially available to suture the tears. Postoperatively, bed rest is often used, and the data behind that is being questioned, especially in the adult population where the morbidity may not be worth it, like DVTs and pulmonary issues. But certainly most of us do at least a day or two of laying patients flat. Caffeine can be good for symptomatology, but it's not really a treatment. You can use up to 200 milligrams in a normal or larger sized child. Epidural blood patches are great. They've been used forever. And there's also new data in high-profile journals talking about occult leaks being treated with epidural blood patches, but you need someone that's capable of doing them, and it may take more than one treatment to be effective. And then diversion drains are simple plumbing based, so you divert the CSF away from the location of the tear, and you do so in a controlled fashion, but this requires being in the ICU usually, and being flat for anywhere from 3 to 7 days and having a controlled drainage. But if none of those things work, revision surgery to do a direct repair remains the gold standard. And getting a tight wound closure is key, because even if you have a small pseudomeningocele, that's better than having any sort of egress from the skin or developing a fistula, which is a huge problem. And putting a subfascial drain here to gravity can be pretty helpful in controlling this so that the fascia on the skin can heal before it exits. So if you identify it early and treat it early, like Dr. Erickson was saying, the outcomes are generally pretty good. There are certainly adverse events, intracranial hypotension, and in severe cases, it can even lead to hematomas and brainstem herniation. Meningitis is a risk, especially if it's coming out of the skin. Antibiotics, the data is kind of mixed on whether or not it actually prevents it. Pseudomeningoceles are almost expected. If it's a small one, the body tends to resorb it. Big ones tend to be a problem, and there's concern for pseudoarthrosis because it may not lead to a good bone healing environment. And fistulas are a dreaded complication. So if I have drains in place, for example, when I remove them, I put a stitch in it. And both in the pediatric and in the adult population, infection rates are higher when a patient presents with a CSF leak, whether intra-op or postoperatively. So prompt recognition and intervention of some sort is the key. And thanks again for having me, and I hope this is helpful.
Great. Thank you. So just given the time, if you have some questions, please put them in the Q&A. The next talk, Dr. Sponseller is actually in China and was gracious enough to record a talk for the session.
Hi, I'm Paul Sponseller. I'd like to talk about proximal junctional kyphosis and its revision. Disclosures are listed. We'll talk about its causes, prevention, and management, especially surgical. PJK is typically defined as a 10 to 15 degree increase versus pre-op above the upper instrumented vertebra. By this definition, it has about a 5 to 10% incidence. It may occur after a definitive fusion, after various types of growing treatments, and even after VEPR or growth guidance. Causes can be mechanical or biological, such as stress transition from rigid to mobile, especially in the presence of patients with ligamentous laxity or who have alignment considerations, such as contractures or stiffness above or below that they have to adapt to. It's also worse if there's osteoporosis or if there's significant growth. Technical factors can also cause this, including excessive exposure proximally, or the choice of certain anchor types, such as supralaminar hooks or wires. And pedicle screws also cause more PJK, it's been shown. Growth is a factor because it's a powerful internal force that acts. Pedicle screws stiffen and constrain the uppermost level and don't allow gradual adjustment. They may over-straighten the span segment, and they need more dissection, especially at the top, to put them in. But junctional kyphosis can often happen even after anterior fusion if you don't even touch the back. This is a patient who I did an all-anterior correction for, and she still had PJK because of the stress transition, even though the back wasn't touched at all. When does it become critical or clinically important? When the risk of sudden failure exists, it may cause neurologic deficit, especially if it happens early on and fast. It may be a posterior element fracture. So the presence of significant UIV pain may be a sign of weakness there. Vertebral translation is the most important thing to be on the lookout for. Proximal junctional failure is PJK that matters. It's defined as PJK with either vertebral translation, a neurodeficit, a vertebral fracture, or the need for a re-op or uproar. Prevention of PJK can be using gradual traction to straighten the kyphosis and to relieve it gradually afterwards. Also, minimize stripping of the muscles and ligaments at the top of your construct, maybe with MIS. Consider using transverse process hooks proximally for a soft landing to allow the spine to adjust itself a little bit. Whether the use of a post-op brace helps is unknown because it also is very cumbersome to use for patients. For those with difficulty in head control, it may be worthwhile. Also, avoid excessive correction of kyphosis preoperatively. Remember that the spine is accommodated to what alignment it was in originally, and it tends to need some kyphosis to stay balanced. Educate the family and therapists what to watch for, especially excessive head lag or kind of a forward look to the spine. Correction of most meaningful cases is almost always operative because PT and bracing rarely make a difference. During surgical correction, you need to resect the overgrown bone around the apex of the kyphosis, often with wide pontes or posterior column osteotomies. Try to use 2 levels of anchors above the kyphosis, not just one, so you have enough to prevent further PJK. Also, you'd like to go from the top down and lock the anchors proximally and then lever them into the previous level of surgery. You need to resect enough of the rod to engage at least 2 pedicle screws. I feel it's best if the rods are collinear with the prior rods, not cross-linked or domino to the side. Bury your anchors as deeply as possible and bend the rod ends down aggressively so they really don't stick out at the top. In summary, junctional kyphosis is common, but sometimes it can be stable and not clinically relevant. Prevent it by anticipation and restrain yourself in the amount of sagittal correction you're producing so the spine can remain in sagittal harmony. Sometimes it's well tolerated, but you want to be on the lookout for PJF, which is PJK that matters. If you see this happening, correct it urgently if it's functionally disabling or unstable. Thank you.
So Paul's not going to be able to answer our questions. Please submit your questions that you might have through the Q&A on the chat. So I'll randomly pick Dr. Cahill. Some of these patients, when you have PJK, it's kind of, you did the talk on adding on. This is the other side up top.
Yeah.
In my hands and the experience, a lot of times you have to go into the cervical spine. Any pearls on that?
Well, one of the things I've started to do in conjunction with one of my neurosurgery colleagues is that I'm using cervical pedicle screws because we have really good navigation. Not a lot of people are doing that. I've only done it a few times, so I'm not ready to totally endorse that as a safe, effective way to go. But before I was doing that, if you went above C7, you were probably having to go all the way up to C2 to really get a stable set of anchors because the lateral mass screws weren't doing much. Some of the other groups like Josh Pays likes to use lateral mass screws and back it up with an ACDF, which I think is a nice solution as well. But yeah, there's a lot of bad options. I think immobilizing people for a while and letting them sort of reprogram themselves. A lot of times this is going to happen in a neuromuscular case. So these are kids that are going to try to get their head back or restore some kyphosis or something that they lost. So I think Paul touched on that. Really don't flatten them out too much, and certainly at the very proximal end, maybe put a little extra kyph into it as a preventative measure. But yeah, once you're chasing it, it's hard. Traction, extending it up, and just hoping. A lot of times it's incremental. Then a year later, you're extending it again and again. So it's a horrible problem.
Can be a gift that keeps giving, tongue in cheek, right?
Yeah.
Thanks for that insight. I like that a lot, and I think we'll have some touches on that in the case studies. Let's move on to our final speaker, Lawrence, who's going to talk to us about revision after VBT. Take it away, Lawrence.
Okay, good evening from New Orleans, everybody. A wise surgeon once told me, don't put it in if you don't know what to do with it when it fails. So we're going to talk about things that fail a little bit. So we're going to talk about revisions of posterior spinal fusions, or two posterior spinal fusion after failed VBT. Are they more complex than your typical spinal fusion? Does the LIV change? And do we need to remove the anterior screws? And then we're going to talk about revision of VBT constructs themselves. This is common if the cord, if you're getting overcorrection, or if you have a failure of a cord early, you may have to go in and revise it. The other time we use this a lot is for adding on. So there's not a ton of literature on this, and these are fairly small groups. They're matched cohorts with, this one is out of Bomber's group, Philadelphia. That's a matched cohort of fusion versus fusion after tether. And in their group, they found there's about a third more blood loss. The transfusion rate was about the same, so maybe that's not that significant. The OR time was not quite an hour longer for the fusions after VBT. There's about a 30% increase in radiation exposure. And in their series, there's about a 1-level distal LIV when they went to fusion. However, they did find that implant density, the percentage of correction, intraoperative monitoring events really were not different between these groups. So the thought was really at the end of the day, these were very similar. Another study with about 22 patients, again, a matched cohort out of the Harms study group, showed no time difference in operative time. So kind of contrary to what the previous study showed estimated blood loss was the same. Length of stay was no different. Interestingly, they did find that about 25% of cases utilized fixation other than screws. There was no added benefit for removing anterior screws. At least that's what was felt from this small group. And there was at least 2 extra levels fused in 50% of the fusions after VBT. You have to remember that was early cases that failed, and a lot of those were done short and added on. So that's probably the reason for those. This was a paper poster at Ichios this year, and this looked at 30. We looked at 30 kids that went to fusion after VBT, and a poll was created that took the pre-op for the tether versus the pre-op for the fusion after the tether failed, and those were all scrambled randomly, so that you didn't know which failure belonged to which initial pre-op X-ray. And in that group, this was looking at if the LIV changed or not. And in that group, the average change was an LIV distalization of 0.5. What that means is that really when we look at the reviewers, there were 4 reviewers, 2 that did tether, 2 that didn't, 2 felt like it changed an average of 1, and 2 felt like it didn't change at all. So maybe some difference, maybe not. If we look at the bigger picture on these patients, there were 12 patients that had an LIV at the distal original level or above it. So some actually moved up, 3 did. And there are 18 patients where the recommended LIV was distal to the original fusion LIV. So tips for conversion to fusion. I can tell you the number one best tip to give you is do a well-executed VBT in an appropriately indicated patient. Your fusion rate should really be well less than 5% if you're doing it on the right patients and doing it well. Historically, those rates are higher, but we also, most of those rates come from our first generation cases. Place VBT screws, so place your tether screws in a place that leaves your pedicles open, at least on most of your vertebra. So you can place the pedicles, the vertebral body tether screw a little bit high. You can place it a little bit low. Either way, you can sneak screws in. Use fluoro or nab on these cases. These shouldn't be freehand cases. Use an occasional stubby. So a stubby is just a screw. If I'm putting a screw in and I need that level, but I'm hitting the vertebral body tether or the vertebral body screw, I'll just put a short screw in. And obviously you don't want to do these on the ends of your construct, but in the middle of the construct, these can be very useful. Try to avoid removing the anterior screws. You really don't need to most of the time. I think I've heard people say they always remove them before fusion, and I just think that's unneeded. And that's a big extra surgery for the patient. If you do decide to remove your anterior screws, the staples are usually buried and hard to get out. If they're hard to get out, just leave them. They don't go anywhere. There's no reason to struggle to remove them. Always have hooks or sublaminar fixation, sublaminar bands or wires available as augmented fixation if you can't get screws in. And really choose your levels like you would for any other case. So a word of caution about double screws. You can see these two cases. There's a first generation case on the left that failed, and then a double tether case on the right. There's not much room to put in screws when you put in, or to put in posterior pedicle screws when you've already got two vertebral body tether screws. I think you can see at L3 on this image on the right that it would be awfully hard to get a screw in there, right? So just be aware of that. I know double cord is getting popular, but it's not always, it doesn't need to be done for every patient, and can create some issues if you have a failure down the road. So this is that same G1 patient that failed. You can see that we actually got great correction. We didn't remove the screws, didn't remove the cord, had no trouble getting great correction regardless. If you look at the third x-ray, the lateral x-ray, you can see here's kind of an example of a stubby where I could not get the pedicle screw around my vertebral body screw. So I just put in a short screw. That's probably a 25. That should be a 35. And then if you look at the fluoro images on the right, you can kind of see my strategy. Squeeze them in where you can, right? So some of these are shot below the vertebral body screw, and then you can see some of these above where it's actually shot above the vertebral body screw. So, you know, I sometimes put them above the pedicles, sometimes below the pedicles, but I just try to always keep in my mind when I'm doing the index surgery that I want to leave room just in case. So when we're revising our tethers, we talked about the reasons why a little bit earlier, but we're starting to do a fair amount of tweeners, so those 8 and 9-year-old patients. And we do those knowing we're going to have to come back. One reason we're doing those is because we've realized that the revisions are not that difficult the vast majority of the times. This is actually a child I did yesterday that is 10 now. We did her when she was 8. She's 10 now. My thought is really once they get straight and they've got that much growth left, I worry about cutting the cord because I'm worried, just a simple release because I worry that the deformity may recur. And so I generally at that point will go ahead and book them for surgery, and we put in a cord that's very loose. And you can see this is the result from yesterday, how there's a lot of slack in all these segments so that if she starts to recur, it'll, you know, hopefully catch it. But I also don't want her to overcorrect further. When I do these, I will really try to get them to really try to accentuate their deformity, their original deformity with my positioning on the table. So here's a child that was 9 years old, Sanders 3A, Risser 0, open tri-radiates. With a 67-degree curve, so it's not somebody I could wait on if I'm going to do a tether because the curve's getting bigger. So we did a vertebral body tether on her, and you can see the first post-op standing on the left. 18 months later, we're already straight, so we know we're going to overcorrect. She's still a Sanders 3A. Here's our first post-op after the revision, and you can see we've recreated the deformity some. At 1 year post-revision, she really isn't modulated much yet because we left a lot of slack there. And by 17 months, you can see she's starting to modulate and straighten again. And she's now a Sanders 4, so we should be out of trouble as far as overcorrection. And hopefully we'll get a little more modulation before she's done growing. So these can look different when you go in. So sometimes you're really lucky, and I'd tell you that's probably half the time where you go in and there's almost no scarring. The lung here was completely mobile. We can see our screws and tether very well. I haven't done anything yet here. We just popped in the chest. Whereas below, you can see a cord that's really covered with a fair amount of scar tissue. Usually it's not the lung. Usually it's a thickened pleura, or the lung the edge of the lung is back there, but there's scar tissue between the lung and the tether cord and the screws. Every now and then there's not. Every now and then you have to find an edge, and it's a little bit more difficult. But in general, most of the time, these are not that difficult. So thoughts when you do these, revisions are feasible. And again, it's kind of been a bright spot in tethering to me is they're not as bad as we thought they would be. Certainly, if you do it minimally invasively initially, you can revise it minimally invasively. We've never had a trouble with that. There's really pretty minimal scarring of the lung to the chest wall. That's not something that we see often. If we do, it's kind of some minimal scarring around the ports, but we don't see it a lot. If I sometimes get revisions from other places, and a lot of times those are open cases. If they're open, we'll still try to revise these minimally invasively. Sometimes it's easier to get around the chest with the scope than trying to do it open. If they've done disc releases in those open cases, the lung really tends to scar to the vertebra. So just be aware of that. If you don't work with an access surgeon, usually on these cases, you probably should. It really does help delineate the lung from the scar tissue that you can cut through easily. And that's all I got. And big happy Thanksgiving to everybody. Enjoy your time with your family next week.
Excellent, Lawrence. Great job. And just want to give a big thank you to the entire faculty for those phenomenal talks, and then especially our moderators. Mark Erickson and Michael Glotzbecker for moderating. Now we'll jump into doing a couple of cases. And I thought, actually, Alan, if I can share my screen.
And Amr, thanks for joining. I just want to point out Amr is actually doing this from China, which tells you his dedication to this process. So thank you, Amr.
No, thank you, gang. Gang, let's kick it off. I think we got a couple of minutes for a few case presentations. Let's just start out with a neuromuscular patient. Here he is, 13 years old, stiff curvature. We go ahead and operate on him. And sure enough, 2 weeks later, comes back with a draining wound. Obviously, Mike has had a lot of experience in this, gave a phenomenal talk. But I just love to run through with the other faculty as to what they would do. I want to know, what's your approach? Do you put a wound vac on? Do you take the bone graft out? How many times do you take them back prior to removing the implants? And Arun, I thought maybe we'd just kick it off with you. So how do you handle this acute infection in this neuromuscular patient?
Yeah, thank you. All too common scenario. I think if you're for sure it's an infection and not a seroma or anything else, it's a return to the operating room pretty immediately for me. I think addressing the issue at hand is important. I usually get labs as a baseline just so we can follow it for improvement to ESR, CRP, white count. And then in the operating room, if it's an acute one, I have not replaced the implants, definitely a washout, replace the bone graft. And depending on the bug, MRSA, usually plan for multiple washouts, and antibiotic durations, usually PICC line and IV antibiotics for 6 to 8 weeks. And then as long as they tolerate 3 to 6 months of suppression antibiotics to at least try to get them to a fusion before, heaven forbid, another late recurrence. At least if they have a fusion, you can deal with it then.
Yeah, it's interesting because very similar process for us as well. I agree with Mike in trying to suppress them for as long as possible. I thought almost every single one of these would eventually come back again. But even 5-10 years out now, some of these patients, they have not actually reignited that infection, at least so far. So we'll see. Pat, anything to add from your side?
Yeah, very similar. I guess I would say I wouldn't replace the bone graft. I usually keep the bone graft and I include that in the irrigation. I just irrigate it thoroughly. Duration of antibiotics, we showed pretty clearly that less than 2 months has a higher rate of recurrent drainage. So we treat these kids for at least 2 months. And then, but yeah, I would try to keep the implants. I usually do a washout, put a vac on it, and then come back 3 days later or so, take a second look, take some more cultures. If it looks clean at that point, then close it.
And then if this kid comes back 2 years later now, so you clear him now, comes back, what's your approach at that point?
Yeah, at that point, this is, especially if they had this infection in the early pre-op period, this is probably the same bug. I would recommend a debridement implant removal. I would explore it and see if there's a pseudo clearly visible, and that would kind of guide some of my decision making. If I did see a pseudo, I would say let's plan on doing something in another month or so. If I didn't see one, I would say we have the option of watching, or we can just go ahead and move ahead with the reinstrumentation again in a staged fashion. And the part that I'm interested in, and I don't really know what the right timeline is, do you reinstrument right away? Do you reinstrument the same hospitalization, or do you just wait for deformity progression? I think when there's kyphosis and when it's neuromuscular, the risk of progression is a lot higher. And I would err on the side of trying to get this kid reinstrumented at some point.
Yeah, and I agree with you, Pat, 100%, and certainly a lower implant density titanium implants. We actually look at some labs to try to help us determine whether it's a week or 2 weeks, but I'd love to hear from any of the other faculty. So you take the instrumentation out, late infection, how do you determine when to re-instrument? Lawrence, do you want to?
Yeah. Amr, I think that's a really difficult question. And if especially with a devastated neuromuscular kid with a chronic infection, if I really try to do everything I can not to take the implants out, first of all. And if that means keeping them on antibiotics for a year, I'll keep them on antibiotics for a year. And if at that point they're usually fused, so at that point I'll usually take the implants out and wash them out. If they're not fused at that point, then I'll go back a couple days later and decorticate them and regraft them. I'm not hesitant to use infuse in those situations, but even if I don't re-instrument them at that point, I'll graft them to try to get a final fusion. But I really try my hardest not to have to re-instrument these kids. So I can't tell you that I have an answer for when I would go back to re-instrument them, except for, if they've obviously got progressive deformity that's interfering with their function, then at that point I would go back and re-instrument them. And it would be after they've been cleaned for, a month, 2 months, something along that order, and they've completed their antibiotics with the instrumentation out.
Good. Any of the other faculty want to make a comment on this?
Yeah, this is Mark. One thing I've added is from Scottish Rite Group 2, learned from them, is when I'm doing the final washout before closure, I'll put some resorbable beads, antibiotic impregnated beads, in the wound. I think it makes a difference. Amy McIntosh's paper was pretty supportive of that.
Got it. Good stuff, guys. We got a few more minutes left. Let's see if we can get through one or two more. Tether revision here. That was a great talk, Lawrence, that you've already given. So here's a child. We'll just run through this. Flexible curvature, T5 to L1, and starts adding on here. Before I tell you guys what I ended up doing, Lawrence, you commented on, the fusion after tether. What do you find posteriorly? Is there any evidence of any posterior fusion in these tethers, or does it appear pretty mobile?
Yeah, really none whatsoever. It really seems like a native spine, except for the metal that gets in your way putting your screws in. It's pretty normal.
Yeah, no, that's been our experience as well. And then you did speak about, revision. Let's say you're going back in through the front. Obviously, a lot of scarring. There have been cases of ureter injuries, and if any of the faculty want to make a comment on this, Lawrence, just your take on that, and is there anything you can do preoperatively to try to minimize in a revision setting coming through the front again?
So I know some people have placed stents before in the ureter to make it a little bit more firm, a little more palpable. We've not done that. We honestly have not had to revise that many retroperitoneal approaches. I think that's fairly uncommon. But again, always use an access surgeon with those. Always take your time and make sure you find the right plane and find the leading edge of your psoas very carefully so you can separate the tissues away. But I think that's really the most critical in those situations.
Yeah, no, we've certainly seen our share of complications after tethering, but we've not seen a ureter injury yet, although I know there's certainly several that are out there. And much like you said, the access surgeon really being aware of where your anatomy is, trying to stay as close to the bone as possible.
And I would, Haber, I'd add that we've had one. It was a while ago, and our access surgeon actually thought he got it closing on the way out. His resident got it with the suture. And you have to be aware of it. It actually, when we pulled our Foley, we started getting urine out of the chest tube. And everybody kind of ignored it. And I said, no, this isn't right, because they didn't think it was urine at first. But the point I was going to make is that you really have to work, when you work with your access surgeon, it has to be a team. And your access surgeon, a lot of time when you're putting in screws and working down there, is blind to what you're doing. So just you have to know where things are, also where your structures are, and be aware as well, just as aware as he is when you're in that space.
Yeah, no doubt about it. I mean, I am hyper vigilant when we're going back in the second time. Quite honestly, even the first time.
Yeah, the first.
particularly the second time. Any of the other faculty, Mark, any comments on the anterior that you'd like? Any tips or tricks on going back in?
I would extra highlight the access surgeon and have it be somebody you're familiar with that you've used before in that area, because it's a revision, so it's always going to be some surprises.
Yeah, Pat, go ahead.
It's real when it happens. As Lawrence mentioned, that there is a hole in the diaphragm, so that urine can then start backing up in the chest. So be on the lookout for that in your revision cases. And I think our urology team, we've seen it enough at our place with cases referred in, where our urology team has a protocol now that they're about to publish on how they decompress the lung and the chest, and then also explore the ureter with scopes and stents and things like that. And then there are techniques for open repair of the ureter and the kidney in damaged tether cases. So it's unfortunately it's more common than we like to admit kind of thing.
Yeah, no, it's definitely out there, and it's good to have a game plan going in and how you're going to handle it afterwards. Gang, just looking at where we are with the time, and I know we have some closing slides coming up that Dr. Erickson is going to take us through, so I'll hand it over to Mark.
All righty. Thanks, Amr. Great stuff. Hope you're not jet lagging too bad. So we have lots of educational material available on multiple sites, as you can see depicted here on this slide, including YouTube. So please feel free to go to these for your resources as needed. Next slide, please. We very much appreciate your participation. The Setting Scoliosis Foundation does provide this education at no cost. So if you would consider a donation, it helps us to keep this alive. You can tell by our faculty they're very interested in educational efforts, and I appreciate you all attending. Next slide, please. We have a host of other webinars upcoming. You can see in 2026 the topics: a CSF leak, a VBT, and a Sherman's kyphosis scattered throughout the early and mid portions of 2026. Next slide. Thank you very much for attending. One final word would be, we change these in an iterative process, and the iterative process comes from the questions that you ask as well as how you fill out the survey. So if you wouldn't mind filling out the survey and giving us constructive feedback, that would be very helpful, and we'll put it right into our next session. With that being said, I'd like to thank the faculty. It was a great presentation, very well put together, and we appreciate everybody's participation.